So welcome and good afternoon. I'm John Ianyan, the Director of the Institute for Healthcare Policy and Innovation. It's my pleasure to welcome you to today's event, the National Poll on Healthy Aging at 5 years and beyond. We have a great panel of colleagues to speak to us today. We're celebrating the 5th anniversary of the poll, which was founded in 2017 as one of IHPI's signature initiatives. And it's a particularly exciting time because the founding director of the poll, Dr. Preeti Malani, who helped to launch it back in 2017, as of the beginning of this month, she became the inaugural JAMA Deputy Editor and Editorial Director for Equity. So we really want to thank Dr. Malani for her contributions to the successful launch and implementation of the poll over the past 5 years in her leadership, and congratulate you on the important new role that you've taken on while continuing to maintain your faculty connection here at the University of Michigan and serve as a special advisor to the poll. And then I'm very pleased to announce that Dr. Kullgren, who's sitting next to Dr. Malani, who served as the Associate Director of the poll for the past 4 years, will now become the poll's new director, and Erica Solway, who's joining us here in the audience, who's been the co-associate director with Jeff, will now be the poll's new deputy director. And then finally, we welcome Scott Roberts. Hi, Scott, from the School of Public Health, where he's a professor and has experience working with the poll team as a collaborator. He'll be joining as the poll's new associate director. So these three leaders, along with other members of the team, including Diane Singer, Matthias Kirch, and other skilled staff from IHPI's communications and policy engagement teams, will help to build on the poll's success over the next 5 years and beyond. And one of the reasons we've been very successful is our partnership with Aarp, and we're honored and grateful to have 3 colleagues from Aarp joining us today, and 2 of them will be presenting at today's seminar: Terry Keenan, who's the Director of Health and Health Security Research, and a new member of our National Poll on Healthy Aging Board, Lina Walker, who's the Vice President for Health Security from Aarp's Public Policy Institute. And then Cheryl Lampkin, also from Aarp Research, has been instrumental in our success with the poll and is also joining us today from Washington, D.C. So now I'll turn it to Dr. Preeti Malani, who will introduce us to the poll's history and as well as our speakers for today's seminar.
Yeah, thank you, John. And thank you, everyone, for joining us today. I think all of you are aware that Americans are living and working longer than ever, and being healthy in every sense of the word, physically, socially, emotionally, spiritually, is important to older adults and their families. And today, the life expectancy in the United States is close to 80, which is 3 decades longer than just a mere 100 years ago. And during the next 10 years and beyond, that population of 50 plus is expected to grow disproportionately to younger adults, almost twofold. And because older adults consume a disproportionate amount of healthcare resources, including the all-important Medicare dollars, this is a really important population. Populations are vital to any discussion around health policy. And the National Poll on Healthy Aging emerged as a way to really understand the everyday lives of older adults and their families, and to really hear directly from people who are actually aging. And for the purposes of this poll, we're interested in U.S. adults aged 50 to 80, so aging and pre-aging. And the goals of the poll were pretty simple. They were to develop, implement, and sustain a recurring nationally representative household survey of U.S. adults on issues related to health, health care, and health policy. And we've always used that term health very, very broadly, moving beyond traditional medical issues to get at overall well-being. In the more than 5 years since the poll officially launched, and again, there was work before that time, we've had almost 50 reports. I think today is report 49, I'm told, so we're getting close to a big milestone. And we've had more than 25 peer-reviewed publications and dozens of poll extras and blog posts, and you'll see a little bit more in a moment on this. And one of the big reasons for the poll's success is the unique collaboration that we forged with AARP. And this is a great example of a non-traditional partnership that has kickstarted important policy work that really wouldn't have happened otherwise. And the AARP team, we're so happy that they're here. They're not just our collaborators, but they're really an extension of the IHPI family, and I mean that genuinely. They have met many of you over their trips, and with the pandemic separating us for the last few years, we're so happy that they're here. I'm going to introduce our speakers and actually also just show you a couple slides of the team. And as you heard from Dr. Ayanian, I have moved on from my role as director, taking on sort of new challenges. So it's an exciting time for me. I'm really grateful to stay on as part of the Poll family. Frankly, it would be very hard for me to leave. It's such an important part of my life. But my colleague and friend, Dr. Jeff Kullgren, is now the director. Erica Solway is the deputy director, and we're so pleased to have Scott Roberts join us as associate director, and we're really looking forward to digging in on issues like caregiving and dementia that he's had such expertise in. Diane Singer, we were so fortunate to have Diane as our poll manager from day one. She had a similar role, or has a similar role with the Mott poll. And again, she's just a core part of our team, always reminding us of what's important in the family and patient perspective. And then, of course, Matthias Kirsch, who is unflappable, never says no to us when we ask for crazy data things, and just also just a key part of our success as a team. He has such expertise in question development, for example, and we're also supported by a number of other individuals that are part of the IHPI family, including Christina Camilli Wisenhunt, who I don't think is here today, but may be joining us remotely, along Eileen Kostanecki, who's been our policy person. Sarah Wang's photo's not here, but Sarah's been a really important aspect of that. Kara Gavin, who has just worked tirelessly to pitch the poll and write hundreds, it feels like hundreds, but maybe not hundreds, dozens of articles on the poll, and just helping us connect with so many media groups. Lauren Hutchins is our wonderful collaborator and helps make sure every word is correct in the reports. Trish Meyer, who of course is so much a part of the IHPI heart and soul, but has also been with us with the poll as a prior role with strategic initiatives, and actually has traveled with us many times to DC. Megan Petiprin, who's just back from her wedding, so welcome back. Megan has helped us with all types of marketing and communications, and then Emily Smith, all the photos that you'll see. Emily is just a genius with graphics, and the other person who's not on here that I wanted to just call out is Stacy Tressell, who, thank you, Stacy, for always helping organize these events. I know it's a lot of work, so we really appreciate it. I just want to introduce our guests formally. Dr. Jeff Kullgren, you've heard his name, I think many of you know him, is the Kutch Memorial Research Chair and the Associate Professor in the Department of Internal Medicine at the University of Michigan, as well as a research scientist at the Center for Clinical Management Research at the VA Ann Arbor. And Jeff is the director now of the poll. Dr. Sheria Robinson-Lane is an assistant professor at the University of Michigan School of Nursing, and she was a faculty collaborator on the April 2022 report on older adults' preparedness to age in place, and she's to Jeff's immediate right. And then we're grateful to have two of our AARP colleagues join us on the podium today. Dr. Terry Keenan is the Director of Health and Health Security Research at AARP, and she's been a key partner really since the beginning, the embryonic stage, when we were still trying to come to get to yes with AARP. So Terry, and I actually was very fortunate to present with Terry at the American Public Health Association pre-pandemic. So nice to see you, Terry. And then, so welcome back. Lina Walker is the Vice President of Health Security at AARP's Public Policy Institute. I'm going to say welcome home to Lina because she's a U of M alum and the newest member of the National Poll on Healthy Aging Advisory Board. And with that, I'm going to hand it over to Jeff.
Well, thank you, Preeti. And on behalf of the whole poll team and really IHPI, thank you so much for your outstanding leadership over these first 5 years of the poll. And we're really excited that you'll remain involved with us as a senior advisor to the poll, and equally excited for your new role at JAMA. So, Preeti alluded a little bit to some of the, just how busy the first 5 years has been for the poll. Tremendous number of accomplishments. She mentioned some of these already. I won't repeat them. I will just add that we've collaborated with over 50 IHPI members now. That is nearly 10% of the IHPI membership in just the first 5 years of the poll alone. Hopefully some of you who are listening would be excited to collaborate with us in the future. If so, please reach out. But we've just been incredibly busy, and we're always looking for new ways to disseminate our results. We are increasingly producing videos with some of our poll findings. Preeti mentioned the blog posts. Our work has been cited in media all over the place, and as well as by members of Congress, and also featured at some congressional hearings. And that's one thing I think in the future of the poll we're particularly excited to collaborate with our Aarp colleagues on, is how we can have even a greater level of policy impact through the National Poll on Healthy Aging. So we certainly spend a lot of time focused on the disseminating our results, but even before that, there's a lot of rigor that goes into our methods. And so just to give you an overview of what we do in the National Poll on Healthy Aging, I'll just briefly mention that now. Our surveys through the National Poll on Healthy Aging are conducted using initially Ipsos Knowledge Panel. We have now transitioned to the National Opinion Research Center Amerispeak panel. These are both online, nationally representative, probability-based panels based in the United States. We field our surveys twice a year, so we have several modules within each of those two fieldings. And our surveys are completed by about 2,000 people aged 50 to 80. The sample data are then weighted to reflect the U.S. population, so everything that you will see here, everything that you see in our results are nationally representative estimates. Our completion rates are high, about 60 to 70% out of those who are contacted to participate. And our surveys are completed either online or by phone now. Initially through Ipsos Knowledge Panel, they were online only. Now through NORC Amerispeak, they're completed either online or by telephone for those who lack the ability to complete an online survey, either because they lack broadband internet access or a device on which to complete online surveys. So those are the methods that we use. And these are some of our most recent poll reports that you can see here. This is just the last 6 months. I think it's a really nice snapshot of some of the varied topics that we cover in the National Poll on Healthy Aging. Things ranging all the way from mobile health app use among older adults. That report had a particular focus on diabetes care. Decision-making about elective surgery. We looked at the impact of the COVID-19 pandemic on decision-making about elective surgery, which affected so many older Americans. Preparedness to age in place. So Dr. Sheria Robinson-Lane will be talking about that work a little bit in a few moments. Women's health. This is a report that we generated a few months ago on sex, intimacy, and menopause. Use of and interest in integrative medicine strategies. So this has previously have been referred to as complementary and alternative medicine. That report explored, for example, how many older Americans are using things like chiropractic care, acupuncture, what benefit they see from that, how they're finding out information about that. Do they talk to their healthcare providers about it? So that's an area where there was not much data known in this particular population to date until this report came out. And then our most recent report was on arthritis and joint pain, a condition that affects so many older Americans. And so that report explored how common some of those symptoms are, what sorts of treatments older Americans are using over the counter through their healthcare providers, et cetera. And most importantly, where there are opportunities to improve arthritis and joint pain care for older Americans. As I mentioned, this work has been covered widely, both in our kind of regionally based media, national media, and even increasingly international media. What you see up here is but a cross section or snapshot of some of the media outlets that have covered our work, and so we're always looking to achieve broader and broader reach in our findings to get get these findings into the hands of people, the policymakers who can do something with these findings, and the older Americans who can use that information to make good health decisions for themselves and their families. After our reports go out the door, we make our data publicly available. So many of you in the audience may be interested in this. You can go to healthyagingpoll.org and you can download our data. We release that sometime after the reports are generated, but we want to make those data available so they can get used. It's incredibly gratifying to see students, faculty members, researchers from all over the country using those data and doing analyses, building off the work that we've done. And today, this report was just released, so this is literally hot off the presses. And this is a module that I was fortunate to lead on at-home medical tests. This is a topic that I think is familiar to so many Americans now, in large part because of the COVID-19 pandemic. Probably if I polled everybody, nearly everybody here has probably put a swab in their nose at home to see if they have COVID-19. And those are but some of the at-home medical tests that are available. There are a host of other at-home medical tests that are out there as well. If you go into any grocery store, any drugstore, you go onto Amazon, there are cancer screening tests that you can get. There are DNA and genetic tests that one can use. Tests for infections like urinary tract infections and HIV, all that can be used in the comfort of one's own home in a private setting. The technology has really advanced, enabling more of those tests to become available. Certainly there's more of a premium on convenience in healthcare these days. And then also many of these tests are heavily marketed. And so these are becoming increasingly available to older Americans, and there's very little data known about how often these tests are being used, how those results are being shared with one's healthcare provider. That's critically important for many patients. And so that's what we explored in this particular module. And these are some of the main things that we found in this module. So what you see here are the proportion of US adults age 50 to 80 who had purchased each of these types of at-home medical tests. You can see here about a third of older Americans now have purchased an at-home COVID-19 test. And then you can see the proportion who had purchased other kinds of at-home tests. If you add up all of the non-COVID-19 at-home tests, we found that 28% of US adults age 50 to 80 have now purchased a non-COVID-19 at-home medical test, almost as common as purchasing an at-home COVID-19 test. So these tests are increasingly being used by older Americans. Beyond purchase of those tests, we were interested in what older Americans think about these tests, what some of their perceptions may be, what some of their concerns might be about this testing. Nearly 3 in 4 felt that at-home testing could be more convenient than tests available through their provider. That's a pretty striking figure. So that means that many older Americans may be looking to these tests in the future as an adjunct to traditional healthcare delivery. Feeling that test results could be trusted as being reliable was less common. 59% of people agreed with that statement, and only 53% believed that these tests are regulated by the federal government. This is a complicated point. Some of these tests are regulated by the FDA and some of them are not. Many people were unclear if these at-home medical tests were regulated by any governmental body. And one of the most important things we found is 82% of older Americans were interested in using an at-home test in the future. So I think when we look at the convenience plus the interest in future use, this is something I anticipate that we will continue to see to a much greater extent into the future. Now, when these tests are used, it's critically important that this information is shared with one's healthcare provider. And so we were curious as to how much of that was going on. So in general, irrespective of whether an older adult had used an at-home medical test or not, 92% agreed that at-home medical test results should be shared with one's healthcare provider. However, when we asked people who had actually used a test whether they indeed had shared those results, we found something different. 90% of the time among those who used an at-home screening test for cancer, they had indeed shared those results. So that was very consistent with that overall attitude about sharing results. However, only 55% of the time among those who used a test to test for infection had they shared those results with their provider. And again, examples of at-home medical testing for infections include things like tests for urinary tract infections or HIV. So I think concerning in a lot of ways that people are either concerned about a condition or experiencing symptoms of an infection and were half of the time not sharing those results with one's healthcare provider. And then only 9% of the time among those who had used a DNA or genetic test had they shared those results with their provider. So those are some very high-level findings from this module, again, that just came out today. You can find more information about this module and all of our other reports at our website, healthyagingpoll.org. Up here as well, we've got the IHPI website. And then please reach out to us with questions, with ideas for modules, with opportunities to collaborate at healthyaging.umich.edu. So I'm going to turn it over now to one of our most recent and really terrific collaborators in our work, Dr. Sheria Robinson-Lane from the University of Michigan School of Nursing.
Thank you. And I'm going to keep it brief. I'm just here to talk about the experience of being a faculty collaborator and hopefully encourage many of you to consider joining the team. I think it was honestly a really fantastic experience. I think for faculty, regardless of where you are in your trajectory, so if you're a junior faculty member or you're accomplished and now doing a little bit more admin work, I think it can sometimes be intimidating thinking about working with a poll and thinking about you'll have to do a lot of the work yourself, but that absolutely is not the case. You get to work with a very collaborative team and you get to really focus on science. So my area of interest is really understanding how older adults and their family caregivers adapt to changes in health in order to age in place within their communities. And so in being a faculty collaborator, I was able to think about the questions that I wanted to include in the poll that, were really based on health-related quality of life in older adults. And then thinking, how do we pull some of this stuff that we would ask in measures and think about ways to add it to the poll? And I didn't have to do a ton of thinking. I just had to come up with the questions, the concepts that I was interested in, and then the team provided a lot of feedback about what would work with the poll and how to ask it in ways that would be very receptive to the participants. It goes very quickly because you do have a team, and so the time frame between developing the questions and the rollout of the poll and actually having data happened incredibly fast, more so than probably any survey that you could probably do by yourself. And then developing the report, that comes out very quickly, had lots of great conversations with individuals developing policy around reimbursement for healthcare expenses, for home modifications, and a little bit of media coverage, and we have a related paper. So you do get some deliverables on your end. And so I think that it's a great opportunity for, if you're already doing work in aging, of course, to think about, are there questions that maybe haven't been asked or that you'd like to ask to a large survey panel? It's a great opportunity for that. Or if you maybe aren't in aging, but have some questions that haven't been asked yet of an older or middle-aged adult population, that could also be interesting because it does start at 50. Do the ages of most people, when you say 50, I'm not old, so don't add me to that group yet. So you can look at and just separate the data out between 50 and 65 if you wanted to, and focus on that if you're not really quite in aging research. So there's a lot of great opportunities. So if you think of an area of research, you can go to the website, as was mentioned, and take a look and see what polls have already been done. You can shoot an email over to healthyaging@umich.edu and make mention of the area of topic that you're interested in. And maybe you're not sure, but you want to be involved in the poll. You can also email too and say, hey, I'm interested in being a faculty collaborator. I don't know what to do yet, but add me to the list. That's really great, and people will reach out and get you engaged too. So I hope that, and you can also reach out to me as well if you have questions about my experience working on the poll. But thank you, and thanks for the invitation.
So, autumn in Ann Arbor. I didn't think it was ever going to happen again, but here we are. And some of you are probably saying, AARP. Why AARP, right? So I see some in the audience who did get mail from AARP, and maybe you're a member, maybe you're not, right? But we're the largest nonprofit, nonpartisan organization for adults over 50 in the United States. We have 53 state offices, including, let's see here, the District of Columbia, Puerto Rico, and the U.S. Virgin Islands. We have about 38 million members. Varies day to day, but that's the last number that I got. And so you're probably wondering how we got involved in the poll. And I do feel as if I was there at the very beginning, even though I wasn't in the meeting. And I'm very glad to see that both Preeti and Erica got the memo about wearing AARP red. So I'm always happy to see that. But the question is really sort of, what is AARP, why are we involved, and what are we getting out of this? So I'm going to tell you a little bit about what we do at Aarp Research, which is sort of the consumer-facing part of the research arm. And then I have my colleague, Dr. Lina Walker, who I'm thrilled is now on the advisory board. She's going to talk about policy. So we have both the consumer lens and the policy lens. And what do we do in Aarp Research? We conduct research on the needs and interests of adults over 50. There's some times that we lapse, we kind of go down into maybe age 35, or we even go down sometimes to 18, to try to get a better understanding of the needs and the interests and the behaviors of what I call midlife and older adults. We also do research on part of AARP's advocacy and legislative agendas. Lots going on Capitol Hill, and always happy to work with Eileen Kostanecki, who is in DC. We track the opinions on a variety of issues of adults over 50, and we often do research on behalf of state offices. I'm happy to say we've done a lot of research on behalf of the Michigan State Office in recent years, probably because of this relationship with IHPI. We also do secondary research in information services. So that's very high level. How are we structured? We're structured in Aarp Research in two large units. There are about 55 staff people in Aarp Research. We have a unit that's called Consumer Insights and a unit that's Strategic Research Services. Consumer Insights is where I am, the Director of Health and Health Security, and we like to talk about health, wealth, and self. So it's health and health security, financial resilience, and I think we're now calling it social connections. If I'm wrong, Cheryl will correct me. And then we also have strategic and local, and membership and brand, which does a lot of the internal research on behalf of the enterprise. Strategic Research Services has 3 units. One is research service, and they actually work very closely with NORC, as does IHPI, on a variety of research projects using the NORC AmeriSpeak panel. We have a library, and we have librarians that can conduct literature reviews and secondary analysis. And then we have communications and creative services. And if you ever find a Terry Keenan report online, and you say, that's kind of nice looking, I didn't probably do it. It was probably the work of creative communications and creative services. They make our work look great. What do we study? Now, this is where things get interesting, and this is where you're beginning to understand why we're working with IHPI. Jeff and Sheria talked about some of the most recent things that have come out, and I think sometimes we argue amongst ourselves on the project team on who's going to do what. Because AARP does research and IHPI does research. And I know sometimes we've kicked ourselves saying, ooh, we should have done that ourselves. Why did we put that in the poll? Why did we let them have it? So health and health security is what you might imagine, Medicare, Medicaid, healthcare, also healthy living. Cheryl does a lot of work on healthy living, brain health, health disparities, and also family caregiving. And I know we've done some work on the poll on family caregiving. I'm hoping we can do some more in the future. Financial resilience, work and jobs, savings and planning, broadband. I also mentioned state level work, utilities and broadband, lots of work on broadband and telehealth. So there's a communication between, or connection between health and financial resilience. Social connections, they do the fun stuff. They do travel. They do fun and fulfillment. They also do things like social isolation. And then strategic and local, this, my colleague who heads strategic and local, she says it's basically people, places, and things. So it's AARP research on livable communities, engaging locally, multicultural disparities, veterans, lots of stuff, people, places, and things. And then membership and brand. As I mentioned, that's the work that's done for internal purposes on our membership, our brand equity, those sorts of things are in membership and brand. But that might have bored you a little bit. So I thought I would show you just the web page. If you go to aarp.org/research, this is what it looked like last week. And you can find all of our reports in the website. And this will just give you a flavor of some of our most recently released reports. One that was done on walking. This was done on behalf of the Maryland State Office. One of my colleagues was speaking at a Walktober event. I've not heard of Walktober, but I guess it's a thing. Okay. My personal favorite, U.S. Caregivers' use of technology. I wrote it, so I like it. Vital Voices research, that's research that we do 53 state offices. Every year, we do surveys on topics of interest in these state offices. She's the difference. You probably have heard some of this because there's an election coming up. So we've focused particularly on women over 50 because women over 50 vote, they read, and they vote. That's a good report if you want to read any of them. Grandparents, we do a lot of work on grandparents under the Social Connections umbrella, and then voters speak out. So this is just a flavor. There may be others that have been more recently released. This is a shot from last week. Erica asked me to talk very briefly about the impact and why is this sponsorship so important to AARP. It's been 5 years, 50 reports, very important to AARP because we're concerned about the views of people over 50. The poll has been a regular cadence of insights about people over 50. Very important. It keeps aging and aging issues top of mind. So it's not just AARP out there talking. It's other people talking and talking in the voices of consumers. We keep track. The National Poll on Healthy Aging has been mentioned 2,333 times between July 1st of 2019 and last week. So it gets lots of pickup. Jeff referred to this, lots of pickup, and the publicity value is 1.9 million. Now, I'm not going to tell you what the sponsorship is from AARP. AARP is a sponsor. There are other sponsors, but this is incredible, the publicity value for the poll. So that's why AARP is involved. We think it is an important sponsorship. We're happy to work hand in glove with the IHPI team, and I'm honored to be here today. I'm going to turn it over now to my colleague, Lina, who will talk about the Public Policy Institute and the work they do there.
Well, thank you, everybody, for inviting me here. It definitely is homecoming for me. It's been a long time since I've been back at Ann Arbor, and a lot has changed. The last time I was here, the Pfizer building was an empty building. Sitting on this lot, there was an IHPI, and the downtown has transformed itself over the years. So I won't tell you how old I am or how long it has been since I was at the Department of Economics. So I was asked to talk a little bit about how the potential for collaboration with the Public Policy Institute at AARP. So I'll talk a little bit about how we use data within the Public Policy Institute. As Terry noted, we are a very large organization, and we have a very large advocacy unit. Now, in Washington, D.C., policy is usually the euphemism for advocacy, but within AARP, we do have a distinction between the policy shop and the advocacy shop. So we try to produce some objective research, but we do very much engage on advocacy support, and that is, in fact, a big part of what we do. Within the Public Policy Institute, these are the areas that we cover. There's health security, family, home, and community, which covers caregiving and home and community-based services and long-term care issues. We have the Center to Champion Nursing in America, which covers a lot of scope of practice, workforce issues, and then we have financial security, I think, which speaks for itself. That includes Social Security, pension reform, 401k, retirement savings. I lead the health security team, and I also lead all the healthcare strategy in AARP, including our education and outreach activities. What's primarily different between what we do and what Terry does is that we focus on a policy audience for most of the policy work that we do. There is a sort of a set of activities that we do in education and outreach. Clearly, that's for a different audience. That's a very consumer-facing audience. We work very closely with Terry's team on all the education and outreach activities. So there are, if I had to bucket it, I would say there are three main categories of how we use data. There's campaigns, which are the political campaigns. There's our policy research and education and outreach, so that's where we write the sort of the longer papers. And then the third is we do a lot of tracking activities. So I'll start with our political campaigns. So we have been in two very large, very expensive, very high profile campaigns the last few years. The most recent was the one around the Inflation Reduction Act, which was previously Build Back Better, and a big part of it was it had prescription drug reform, prescription drug pricing reform, and it also included, like, not, little known because it was a small part of the bigger package, extension of the financial subsidies in the ACA, in the Accountable Care Act, which is the marketplace for individual health insurance coverage plans. So we did a lot of work advocating for that particular bill and those provisions. And the type of work that we do in these kinds of campaigns are really fast turnaround analysis. So these are long nights, long weekends, and we usually rely on information that we have sort of built up over the years. So we have, we kind of know, like living in Washington, D.C., you kind of know what has legs and what's not going to have legs. So you can sort of anticipate what's going to come down the pike in the next year or so. So you prep ahead of time for it. And so then you have the resources at hand, and then you sort of package it and use it differently. So in terms of how we could, again, structuring my remarks around how we could potentially collaborate in the future, so in these sort of quick campaign type activities, one way we've partnered in the past was during health reform in 2017, was when we needed access to data. So there was an amendment had dropped, and we needed to figure out how that particular amendment was going to impact older adults. And we needed insurance claims data really quickly. And so we reached out to an academic center because we had relationships with different academic center. We reached out to an academic center where we knew they had the proprietary claims data. They had purchased it. A lot of these data you purchase it, so then you have access to the data. So we reached out to them and said, this is the type of information we need so that we can understand what's happening with this amendment, but we need access to the data. So then we became members of the group so that we could access the data, and then and they were incredible. So they helped us with that analysis, and over the weekend generated the information that we needed, and then we could publish in a blog. And in fact, in that particular instant, that was very useful because that information was particularly salient to a member of Congress in Maine. And so we have state offices in all the states. And so we could take it to the member of Congress and say, this is how it's going to impact, individuals in the state of Maine. Similarly, I would say in this last go around in the Inflation Reduction Act, a lot of the data that we generated was state-specific information because Arizona and West Virginia data was particularly impactful in the ability to move the legislation through. So for us, in these kinds of campaign, having state-level data is really important. Even better, we can get congressional level data, congressional districts data, but those are really, really hard to come by. So state level is really, really important. The policy research and education activities that we do. Where's my water? Okay, so this is just a flavor. And I'll talk a little bit about how kind of they're different. So I have some examples. Let me pull out my examples. Okay, all right, so here. How does a policy affect people? So I'll start by saying that we are a small team. So we don't actually do the data crunching in our institute. We partner with researchers. We partner with academic researchers, and we partner with, there are a lot of think tanks in Washington, D.C., and people do a lot of research, so we partner with them. We also do a lot of contract work. There's a lot of vendors in D.C. But all of the work that we do, we work with them to figure out, like, how can we understand how it's going to impact people? What does the policy actually do? And who is it affecting, and who is it not affecting? And what does that mean? Like, some people left out left outside the umbrella, for instance. So an example of how does a policy affect people. Now, these types of research usually take a longer time. We expect they'll take several months, sometimes a year or two. That's really unusual. We contract for a research project that lasts a couple of years, I would say, but we have done that. And one particular example was trying to understand Medicare buy-in, for instance. How does Medicare buy-in affect individual? Well, it turns out the result was counterintuitive, right? People in Washington, D.C. were saying Medicare buy-in was a solution to address the high premiums in the marketplace plans. So if you offer Medicare buy-in, then prices in marketplace plans would fall because the older adults would move out and buy into Medicare. It turns out that wasn't the case. And so that research was really illuminating because it changed the conversation in Washington about how to address the affordability issue in the ACA. An example of what the policy is doing. So there's a lot of work right now around telehealth. It's like the hot button topic. But for us, from the policy side, we don't even know what telehealth is doing. Like, you have telehealth for maintenance, telehealth for diagnostics, telehealth for different types of services, telehealth in different modalities. What is telehealth replacing? Is it new services? How does it impact spending? How does it impact out-of-pocket spending for the program like Medicare and Medicaid, and how does it affect spending for individuals? So for us, when there is a new policy like telehealth, and there are others that come up, right? Our question is, what is it even doing? And because I'm an economist by training, it's like, how is it changing the marketplace, and what kind of perverse incentives or, fair incentives is it producing? So that's something we need to know so that we know how it impacts people. And then for us, the bottom line has always been affordability, right? Access and affordability. And so those are the kind of the two domains that we always plan our questions and our research around. The last question, we want to know who's affected by policy, but we also want to know who's missing. Like, who are we not helping by rolling out this policy? Who have we forgotten? Or what we're doing most recently is there are tons of programs out there, and there are many people, almost, you can say a broad stroke, about 50% of people who are eligible for programs are not enrolled in them. Tons of different reasons. Cuts across the low-income programs, LIHEAP, MSP, SNAP, and then even like the ACA and Medicaid expansion, for instance. So now we're spending a lot of time trying to understand who are the people who are eligible and yet not leveraging the benefits that are available to them. Because, if you just think about it, that's the low-hanging fruit. That you don't have to move legislation to get them the financial support or the coverage that they need. They are already eligible for them, but somehow they're not using them. And so the who is really hard to define because there's just not there's no very good data out there. Right? So we work with a lot of researchers to try and figure out how do we model who's, the probability, the likelihood of being eligible and not enrolled. But anyways, that, I would say, is a really big opportunity for potential collaboration if anybody's interested. And finally, moving on to the last bucket, which are trackers. We do a lot of trackers, partly because things are evolving. There is even outside of public policy, the marketplace is changing and evolving constantly. State legislatures are always doing tweaks to this and that. So we have tons of trackers to just keep our eye on what's happening. We have the Ltss Scorecard, which is a tracker, and it's just like, I don't know, 100 different indicators of like all the different things that are meaningful to people and their family when it comes to making decisions about long-term services and supports. So that's one kind of tracker. We have a tracker that's the livability index. And so it's like, what's a good place to live? And so, there are different ways of measure, a lot goes into what makes a place livable: affordability, income, jobs, safety, environment, access to healthcare, parks, etc. And so we track all that in the livability index. And we do tons and tons of tracking at the state level, for instance. So I'll give you an example of some tracking that we did that eventually helped in the most recent Build Back Better and Inflation Reduction Act type of work that we did, advocacy work. So we did for the last 10 years or more track the price of specialty prescription drugs, generic prescription drugs, and name brand prescription drugs. And we worked with a researcher over at the Prime Institute in the University of Michigan. So for 10 years, we would publish the data, how that has changed. And then we, build a market basket of all the different prescription drug prices that are commonly used by older adults. And you can see how it has gone up over time. For 6 years or more, people would say, why are you tracking this? Who cares, right? It's like the same set of drugs. People use the same set of drugs. Well, all of a sudden, now this is really important information. So part of why we track is because this is relevant for us, and it takes time to move, for legislation to move. And legislation is all about timing. So you need to have the data on hand if the legislation has legs, and then it moves really quickly. And so part of what we do is we track so that we can be ready when Congress is ready to act on something. With that, thank you.
Thank you so much for those great presentations. I think about where we started, just an overview of the poll, how much productivity we've had, some of the topics, including the one that just came out today, which is really great and timely. And to really think about that, I have to say I didn't realize all the tests that are available until I started spending more time in drugstores, waiting for various members of my family to get their COVID shots. And it's quite interesting what you can buy in the stores. And again, as a physician, the idea that patients might come to me and say, I took this test for an infection. And then we heard, of course, from Sheria Robinson-Lane about her experience, which, thank you. We didn't actually tell her to say all those great things, but I was really pleased to hear that. And again, we try to make it very easy for collaborators to work with us, even if it's an idea, to sit down and discuss it. And we've had some situations where people have an idea and it takes a few tries to get it right. And one of the best examples is Sue Ann Bell's work on emergency preparedness. She didn't give up, and frankly, that work has been so critical, even now with Hurricane Ian and the devastation that's occurred in Florida. Just, again, talking to policymakers. And actually that link that Lina talked about with policy and advocacy. And then Terry, thank you for your comments about what's in it for AARP. And again, really remarkable to think about how important the issues around aging and healthcare utilization are, for our entire nation, really for our world. Some of our work goes beyond the U.S. And then Lina, again, talking about some specific topics. And I heard things, I wrote down some notes here, telehealth and broadband and social isolation and multicultural disparities. I think these are all things that we are thinking about as we move forward. And, I think I'm going to kick us off with a quick question, and then we'd love to hear from the audience. That dyad of advocacy and policy that you spoke about, it occurs to me that a lot of people in our audience, both in this room and who are joining us by live stream, this is something that they're doing. These are policy topics. And what have you learned in terms of, you're an economist and you talk about theory and policy, but yet ultimately you're talking about patients and families.
Can you hear me? Hello?
Yeah.
Great question. Thank you so much. Well, so one thing that always resonates when we're producing data for our advocacy colleagues is what is the impact on individuals, and provide the data at the state level. Now, the thing about policy research, though, is that the details of the policy has a huge impact on people and kind of the distribution of outcomes. So it's helpful to have some averages or the median, but really the more important, sort of like the more impactful kind of analysis we've found is when you talk about how, I don't like to use the word winners and losers because it's not really always a zero-sum game or competition between groups, but definitely because when policy rolls out, it rolls out within certain parameters, and so people fall along the spectrum of how it's going to touch their lives. And so to really impact policymakers, you really have to talk about how that policy is going to affect people and how it affects them differently, right? Because then that makes it more real to them, and then they understand. It's more powerful when you're able to say this particular population is really going to be adversely affected because of X, Y, Z, less so because of that. Because when we move policy, often it's sort of like it's tweaking around the edges. It's not a yes or no to something when you want to move it in Congress. Sometimes it's like, is it a little bit more? Is it slightly narrower? Can you, make it like pink or blue or whatever? And so having a sort of more fuller understanding of how it impacts different groups of people and why and how gives you more power in helping to craft and shape legislation.
Yeah, thank you for that, those comments. And I'm going to ask the audience for their questions and comments. You've got, a lot of expertise up here. Jeff Halter, please.
Thank you all. Wonderful presentation. Congratulations. Fantastic program. I'm retired geriatrician. I want to thank Jeffrey and they did a wonderful chapter for us for our geriatrics textbook that I can see there. That was just published a few months ago, and early include our work. And much for that. There's another National Academy of Medicine months ago, the report. And this is kind of the opposite of what you guys do. High level people all around the world getting there. What can be done worldwide to make life better for people. But there was nothing in there about what people want. Very little. So I was just thinking how maybe my friends wrote the report. I can maybe, for example, as a specific report about the longevity dividend. Under healthier, work more, can volunteer more, can testing, but what if people want to work more as they and then that's not in so you're doing work.
Thank you. I'm just going to repeat the comments from Dr. Halter for anyone who's joining us for live stream. First of all, thank you for the opportunity to contribute chapter to the hazards checkbook, the textbook, the hazards and Halter, and many others, which is really the premier textbook of geriatric medicine. It's the one I read. It's one that I think you gave me when you were my division chief long ago, and it's just it was a thrill. It was a lot of work. Jeff and Erica and I, and of course the rest of the team supported that work. And Emily's beautiful drawings and figures are in there. But your comment is really about the National Academy's roadmap to longevity worldwide. And one person who's not up here today, but who had joined us earlier in the year is another AARP friend, Vijay Iyengar, who has actually focused a lot on the global aspects, and his own work is very much in the global sphere. And aging is a little different around the world, and so I think those comments around like longevity and really the patient voice or that human voice is something that it's interesting to hear that it is missing. And I don't know if others on the panel have questions or comments on this.
I would just refer you to the longevity economy work that VJET and others in global aging are doing at AARP. You're probably already familiar with it, but every time I have an opportunity to plug something from AARP, I take it. So there it is.
And I know that there's other work that's going on. The National Academies just met and did a national caregiving conference, and the proceedings for that meeting will be published probably really soon. So I participated in it. Other folks that are actively engaged with, listening to the community, actual caregivers were a part of that. So I think that message is getting out of there, and the space is becoming more inclusive, and there's more listening that's happening to direct policy.
Thank you. Are there other questions from the audience? I know we're just up against our 3 o'clock ending time. Kind of going once. Otherwise, I think we can call it, and we'll also be around afterward if people would like to ask questions one-on-one. So thank you so much for your attendance and for your support, and thank you to our wonderful panel, and especially our colleagues from AARP, as well as to Sheria Robinson-Lane, who has been, really among the best collaborators we could ever have. Thank you.